facilities suggests that this must have been going on for a while. Does anybody have a sense of how long this outbreak has been underway? And in terms of Tanzania, do you know if they have yet sequenced the virus from their cases and compared that sequence to the 2023 outbreak to see whether or not this is a case of viral persistence, or compared it to the outbreak in Rwanda to see if maybe this was a spillover from the Rwandan outbreak? Thank you.
Thank you, Helen. Over to you, DG.
Thank you. I will answer to some of the questions, but I think we lost Helen for the beginning of her question. Then maybe either she will repeat or other colleagues, if they got it, they will help. Kerry, I had an interview with CNN where I clearly said the US is the main partner for Africa. We are grateful for what we got from the US. Let me remind you that in 2023, Africa got $8 billion. And out of the $8 billion of assistance from the US, 73% were mostly in the health area, including humanitarian situation. And in addition to the call that we made to give exemption to the some of the response activities that we have, including HIV, we also requested we show our availability to meet officials in the US and to discuss that. But as you know, the hearing process of the Secretary of Health started yesterday. This is the person who is our counterpart in the US. Then we'll wait to see this process finalized with officials, and they know that we are meeting very soon to discuss the collaboration Africa-US based on our mutual interest and using a new narrative, because as I said, it's now time not to talk about assistance anymore, but to talk about this innovative financing mechanism that can help to have a kind of win-win. I will talk more about it maybe very soon, because we started some discussions with senior officials in the US. Regarding the Marburg and Ebola issue, as I said, I didn't get the first part of your question. But what I got, you are asking for how long this outbreak was known in Uganda. The information that I have, we are talking about a week ago, but this is what I have today. Let us continue to confirm and to know more about this outbreak. Then we can communicate. But let me hand over to my colleagues, IMST and others who can provide additional answers. Dr. Ngash and colleagues, and Wesam, if you're also connected, can you please provide additional information?
Yes, thank you very much, DG. I think one of the questions is to know when the result of the ENRB will be ready. I spoke to the ENRB team lead today, who confirmed that the results were first tested in Bandaka. They were tested negative, and the samples, they have received them now at ENRB, and they're expecting that this afternoon they might get the result. I think that's what we are following with ENRB to see if there will be confirmation of negativity or they'll have a result that is different. There was a question on the duration of the Uganda case, as you responded, DG. I think the PS in her statement spoke about a history of 5 days of and then that died yesterday on 29th. That means that fits very well within the non-incubation period of 2 to 21 days, with the average around 6 days. I think it seems to be more with a recent case, but they have already deployed the teams on the ground that have identified the contacts that are now being followed. And then the last question, if I got it, was on Tanzania, if there was sequencing. We haven't received any information to that, but our team is still in Tanzania. I think with some, if there's anything that have come of late, I think you can update that. Thank you very much, DJ.
Thank you. Wessam, are you connected? Do we have colleagues from Tanzania who are connected? Okay, I think we are following that. Once we get the result from the sequencing, we'll make it available. And in Rwanda, it took some days or months for us to do the sequencing and to know that it started with birth in a specific region. We'll do the same. We'll do all studies in Tanzania to understand if this one is linked to the Rwandan outbreak or it's linked to the old outbreak that we had in Tanzania. And then we can make some conclusions. Over to you, Margaret.
Thank you, DG. Let's take the next two questions from the chat group. We have a question from Daniel Lawyer, a journalist at Agency France Press. He asks, during the CNN interview, Dr. Kasea said that the chaos in DRC and the new MPOX variant could result in a major pandemic. Could you please explain why and how this might happen? Then the next question is also on Goma, or about how the conflict is affecting data collection and vaccination. This is from Jill, a senior journalist at BBC Monitor. Over to you, DG.
Thank you. Thank you so much. Yes, I said that. If you see the clade 1b that came from this virus that mutated in the eastern part of DRC, what were the factors for this? First, overcrowded camps where internally displaced people are living. Second, this movement of people due to insecurity. And third, having so many people in the city without access to basic services. Then we got clade 1b. And let me also tell you that because of this clade 1b, that we declared MPOX as public health emergency of continental security and followed by WHO that declared that public health emergency of international concern. Today, we are facing even more than what we had before in terms of the clade 1b detection. We are alerting. Our role is to alert based on the model that we have, based on the analysis that we are doing using data that are available. We are saying, if we don't stop, we are putting all of these conditions together. Now we have people coming from other places to Goma, but we have also people moving from Goma to other places. We are talking about 36,920 as the population density. I don't know if you can visualize that, how people are living without having houses, without having access to water and sanitation, without having access to any medical countermeasure. This is why we are saying learning from MPOX clade 1b, we don't know what we can have. Don't forget that in Gaza, we saw polio restarted. What can happen in Goma, in the eastern part of DRC, we don't know. And we don't want to be accused if tomorrow there is a pandemic to say what Africa CDC did to prevent that. This is why we are calling our partners and our leaders to make a strong decision. Let me ask colleagues from IMSC for the second question, then Margaret will be back to you.
Yeah, thank you very much, DG. I think on the question about the services in Goma, until now, there is no power, there is no connectivity. I think they have started restoring water, and many of the facilities were completely disrupted and destroyed. I think that's the reason why most of the services have been interrupted. But we hear that there is some calmness, I think, that is happening today, that there are no more bullet shooting in the city. And we are hoping that once the electricity and connectivity are restored, and then the health facilities also start functioning, some of the services will be restored. But for now, there is a really complete disruption. Over to you, Director.
Thank you. Let's take the next two questions from the floor. Cameron from Politico, you have the floor. Over to you.
Thank you so much, Margaret. Just in terms of the Marburg virus outbreak in Tanzania, I was wondering, what are the challenges there compared to the response we've seen in Rwanda? Why is the virus so deadly there? What's missing in the response? And I was also wondering if the change in administration here in the US and the temporary freeze of aid has in any way impacted that response and made it harder to respond promptly to it. Thank you.
Thank you. Let's take the next one before DG comes in. Paul from the Lancet, you have the floor.
Yes, thank you very much. So my first question has to do with, can we have an idea of how much Africa CDC has spent on its own so far on the MPOX response? And for the situation in DRC, do we have direct insights into how the ongoing crisis has affected disease surveillance in the country? And last question on Uganda. We know it's a Sudan Ebola virus. So what is unique about the toolkit needed to respond to this particular kind of Ebola virus, and what capacity or tool sets are currently available? Thank you.
Thank you. Over to you, DG.
Thank you. Thank you, Carmen. I will start with you, and I will also provide some comment from Paul's question, and colleagues, they will provide additional comment. I was shaking, to be honest with you, when there was this US pause regarding the response in Tanzania. If we have to talk about MPOX, you know, we have a pledge of 1.1 billion, almost more than 500 million from the US. We got around 60% from what the US committed. And we were waiting for this 40%. And you know, when we talk about MPOX, we just don't talk about MPOX. We talk about integrated approach to tackle all diseases. It means without funding from the US for MPOX, but also for this outbreak, we didn't know how we can really respond to this outbreak. But we are glad, as I was saying, I don't want to talk about the past anymore. Let us talk about the future. we are glad that they give us exemption. And I will send an official letter to the Secretary of State today to thank him for that and to continue to work with all other agencies for the continuity of support. When we talk about the response in Rwanda and in Tanzania, we need also to recognize that Marburg in Rwanda was in Kigali. Then the notification was quick, and we have all commodities in place, and we are able to respond very quickly to that. When we talk about Tanzania, the outbreak is in Kagera region. It's a little bit far from the capital. And we know all issues related to surveillance system in Africa. And the second one, it's about, as I was saying, when we can declare quickly an outbreak, we can also get quickly support. But due to all issues that I'm talking about, Tanzania didn't declare quickly the outbreak, while Rwanda declared the outbreak from day 0. But what is important is now Tanzania is working closely with us, with other partners, WHO and others. I was talking with a number of partners in Tanzania. And I think we'll get there. Things will be resolved very quickly. But this is a lesson learned that we are having. Paul, you are asking how the ongoing crisis in DRC can affect the disease surveillance. It's obvious. When we talk about disease surveillance, we talk about human being, we talk about community focus, we talk about health focus. We are the front line soldiers. But if these people cannot be there because the security is a major issue, how do you want us to perform surveillance? But in addition to that, we have some infrastructures that are destroyed. We had a big lab in Goma. I cannot talk about what is happening to this lab today. And you know, all of that will affect our capacity to have a strong surveillance mechanism in place. Having also people moving from a place to another one is affecting the capacity of the government in DRC to have a strong surveillance system. Yes, the ongoing crisis is affecting the surveillance system in place, but is also affecting how the government is allocating resources, because now surveillance system is no longer maybe a priority as it was before. I think we are very concerned about what's happening in DRC, because that one is not just for DRC. It can affect 3, 4, 5 countries at the same time. IMST colleagues, I think Paul has another second question, if you can help also to answer.
Yes, DG, with respect to the...
Thank you very much. I think
Yes, I see Hadith. Hadith, please go ahead.
Hi, DG. This is Wissam.
Okay.
So regarding the question about Marburg in Tanzania and why we have this high mortality rate, I think we need to address 3 main issues here. The first one, as you highlighted, DG, the early detection. It was not that early when we are coming to the case of Tanzania incomparable to other countries. This is why one of the main areas that we are discussing with the country that we need to strengthening the surveillance system We are speaking about areas that very far from the capital. For us to reach to this area, we almost spent like 12 hours, taking 2 flights plus long road trip to reach to the affected area. So strengthening surveillance system in this area is very critical to early detect the cases. Second one, lab capacities. It will not be enough to have good lab capacities at the central level, but decentralization, this is one of the lessons learned during COVID-19 and also strengthened during response to MPOX. We need to have good lab capacity, especially at this peripheral area, because sample transportation from this far area to the central level will not help us in the early detection. And we're working with the Ministry of Health to know their needs about what kind of additional lab equipment and lab test kits that is needed to strengthen the lab capacity in this remote area. Third element is related to the treatment protocol. We have noticed that, as you are aware, there is no specific drug approved for treatment of Marburg, but there are some candidate drugs under trial, and some of those drugs have been used in previous outbreaks in Rwanda, for example. Yesterday, during the IMS meeting, Africa CDC presented some of those drugs, and we submitted all the documents needed to the Ministry of Health to start thinking of considering some of those drugs to be used for treatment, either under compassionate use or clinical trial. And this is important, conducting clinical trial during this stage to also strengthen the knowledge about what kind of effective tools can be available for this current outbreak and for future outbreak. So I think if we work on those 3 pillars, strengthening surveillance system, decentralized lab capacity, start introducing some of the drugs, this will be help to have favorable outcomes. Over.
Thank you, Wessam. Just to complement the question from Paul, I saw, excuse me, Margaret, but I saw a question from Kosuke Moriwaki, I think from Japan, who's asking if the LC16 that landed in Kinshasa last week can still be available in Goma, knowing that Goma airport is now under the leadership of a rebel group. I can't answer, honestly, for now. But what we'll do, our role is to advocate. We'll see what could be all possibilities. We are talking about public health. We are not politicians. Our interest as leaders of health in Africa is to have all people, irrespective where they are living, conditions where they are facing. For us, it's to ensure that they have access to all commodities they need. I will start conversation with DRC authorities, and I will let you know maybe next week during our next press conference what Africa CDC could do to help to have these vaccines reaching our people in Goma and other places, because we need that to vaccinate children, but we are also calling for more security. I made a decision not to fly out of Goma, our colleagues from Africa CDC who are in Goma. We discussed with them. They told me, DG, they need us. We are still important to this population. Don't ask us to go out of Goma. But you know, this is a very difficult decision, and we are evaluating the situation on a daily basis. We hope that we can give access to these people, to this LC16 vaccine, but also other commodities. The team, IMST, and our other colleagues in Africa CDC, we are 200% mobilized to provide support for this humanitarian crisis, but from the health sector. Over to you, Director Margaret.
Thank you, DG. Let's take the last question. Gabriel Emmanuel from NPR News, you have the floor.
Thank you very much for doing this. I wanted to follow up and ask a couple quick questions about the MPOX situation in the DRC. First, I was wondering, I know you said 40% of the aid from the US hasn't arrived. I'm wondering what the situation is with the vaccines that the US has committed to donating. And also, if you could say more about the lab in Goma that you referenced, that would be helpful. And the last thing, I believe you referenced this earlier, but I know that with the CDC not working with WHO, are they still working with you and communicating openly? And if so, are you kind of something of a third channel, a channel to be able to liaison between the US CDC and the WHO? Thank you very much.
Over to you, DG.
I will ask Chanel to answer. Please, Chanel.
Great, thank you. So regarding
Just talk. They will.
regarding the question on the doses that have been donated by or pledged from the US government, so they pledged 1 million, approximately, well, maybe a little less than 100,000 were shipped before the end of the year. And we don't have confirmation on the remaining availability. So we're working with them to find out when the remaining doses can be available.
Okay, colleagues from IMST, any addition to this answer? If not, I think we can proceed. Director, back to you.
Yes, and with that, we have come to the end of the weekly briefing this week. I will hand it over to you, DG, for your closing remarks.
This week started on very difficult mode. We woke up with this announcement of 90-day pause on the foreign assistance from the US. This week started with this open war in Goma. This week started also with these suspected cases of Ebola in DRC and ongoing MPOX, cholera outbreaks. It's one of the weeks we don't like in Africa CDC because in addition to that, we have the humanitarian crisis. But it's also why we are Africa CDC. Because we are there to show to our member state, to our populations that we'll do everything possible to support. We are working with other partners to provide appropriate and comprehensive support to our people. We don't have all answers to your questions today, like if vaccines will reach Goma, like what will be next in terms of mortality and morbidity in Goma, like what's happening exactly with the Ebola outbreak in DRC and in Uganda. We don't have answers to all of that. But we hope we'll work again hard to get more information, and we remain available for you. If you need to talk to us, the whole team is available anytime. We are transparent in Africa CDC. And this is the change we are bringing in Africa. How to be more transparent, how to better communicate about challenges that we have, and how to raise more domestic resources. I want to invite all of these journalists, if they can join us in Addis Ababa on the 14th of February, where we have a meeting called by President Kagame for all heads of state to discuss sustainable financing mechanisms for health in Africa. I think it will be an opportunity for us also to see how we are engaging our leaders to provide more domestic resources. We are saying that because, as someone told me in one of the Western countries, we are entering a new era where we will see definitely the decrease of foreign assistance to Africa. It means ourselves as Africans, we need to take care and to take the ownership. That one, plus local manufacturing, plus digitizing the system in Africa will be my key focus for 2025. I thank you, and I hope to meet all of you next week, but also on the 14th of February in Addis Ababa. Thank you.